Welcome back to 10-Minute Community Medicine. Quickly before we start, please subscribe, like this episode, and drop your next topic request in the comments. Your suggestions shape our syllabus. Today's focus is the National AIDS and Sexually Transmitted Diseases Control Program, especially Phase 5. Dr. Joshi, could you set the stage? What is this program and why does Phase 5 matter for our exams?
The National AIDS and Sexually Transmitted Diseases Control Program is India's flagship response to HIV and other sexually transmitted infections. Phase 5 runs from 1st April 2021 to 31st March 2026 as a central sector scheme fully funded by the Government of India with an approved outlay of Rs 15,471.94 crores. It is designed to carry India towards the 2030 goal of ending AIDS as a public health threat.
So in one line, what are the Phase 5 goals students must reproduce in an exam answer?
Write this exactly. By 2025-26, reduce annual new HIV infections by 80% from the 2010 baseline, reduce AIDS-related mortality by 80%, achieve dual elimination of vertical transmission of HIV and syphilis, eliminate HIV/AIDS-related stigma and discrimination, and ensure universal access to quality STI/RTI services for at-risk and vulnerable populations.
That dual elimination phrase pops up often. Dr. Joshi, how is Phase 5 operationalizing these goals?
Phase 5 crystallizes 4 big shifts you can quote. 1. A strong prevention backbone through peer-led targeted interventions for key populations, now complemented by community-based screening and digital outreach. 2. A treatment for all stance, the test and treat policy, plus universal viral load testing and dolutegravir-based regimens to drive viral suppression. 3. Active find, link and retain through Mission Sampark to bring back those lost to follow-up. 4. An enabling legal environment via the HIV and AIDS Prevention and Control Act 2017 to dismantle discrimination.
Dr. Joshi, students keep asking about the famous 95-95-95. How is it framed in Phase 5?
Phase 5 adopts the UN AIDS care cascade explicitly. The objectives state 95% of people at highest risk should use comprehensive prevention, 95% of people living with HIV should know their status, 95% of those who know should be on ART, and 95% of those on ART should have suppressed viral load. Additionally, 95% of pregnant and breastfeeding women living with HIV should achieve viral suppression to reach elimination of vertical transmission. There is a social objective too. Less than 10% of people living with HIV and key populations should experience stigma or discrimination.
That's neat and quotable. Could you walk us through the service delivery stack? What does a patient actually touch?
Start with prevention through peer-led targeted interventions run by community-based organizations for female sex workers or FSWs, men who have sex with men or MSMs, transgender persons, and people who inject drugs or IDUs. Add outreach to migrants and truckers. For testing, there are integrated counseling and testing centers or ICTCs, facility-integrated sites, and community-based screening using rapid tests. A confirmed positive person is initiated on ART immediately under test and treat policy with routine viral load monitoring to ensure suppression. For pregnant women, provider-initiated testing in antenatal care plus prophylaxis and effective obstetric and infant regimens achieve prevention of parent-to-child transmission or PMTCT. All these are supported by a strategic information system that tracks the cascade and flags gaps.
Case Vignette 1. 28-year-old truck driver presents at a community camp with recurrent ulcers and weight loss. Rapid tests confirm HIV positive. Dr. Joshi, how would Phase 5 streamline his path?
First, diagnose and treat the probable STI at the camp or a linked clinic. Phase 5 stresses universal quality STI/RTI services. Second, same-day linkage to the nearest ART center for initiation because treatment delays increase onward transmission. Third, baseline labs and a clear plan for viral load monitoring. Fourth, enroll him in adherence counseling and virtual follow-ups. Digital nudges plus community support reduce loss to follow-up. Finally, screen for TB, hepatitis B and C, and mental health. Phase 5 integrates with national TB and hepatitis programs. If he is often on the road, consider multi-month dispensing to maintain suppression.
Nice application. Now the exam love structure. Could you give us the Phase 5 pillars in a memory-friendly way?
Think of 5 P's: prevention, people-centered detection, prompt treatment, positive living, and protection of rights. One can elaborate under each heading.
Dr. Joshi, any epidemiological nuance that Phase 5 addresses?
Yes, epidemics are not uniform. In several northeastern and eastern states, IDUs drive transmission, so Phase 5 doubles down on harm reduction, needle syringe services, opioid substitution therapy, overdose prevention, and hepatitis C testing. Recent state data from Assam, for instance, show injecting drug use contributing a large share of new infections, underscoring why differentiated prevention is essential.
Case Vignette 2. A 24-year-old primary gravida diagnoses HIV during routine antenatal screening at 14 weeks. How does Phase 5 push us towards dual elimination here?
Step 1, immediate ART initiation for the mother, no waiting for CD4. Step 2, integrated antenatal, intrapartum and postnatal care with emphasis on adherence, viral load suppression, safe delivery planning and infant prophylaxis. Step 3, early infant diagnosis and follow-up to confirm serostatus. Parallel screening and treatment for syphilis must run alongside because the target is elimination of vertical transmission of both HIV and syphilis. The program's objective of 95% viral suppression in pregnant and breastfeeding women is key to closing residual transmission.
Let's switch gears to governance. If asked to sketch the architecture in short notes, what should we say?
At the apex is the National AIDS Control Organization. Each state has a State AIDS Control Society that plans and implements with district AIDS prevention and control units embedded in district health systems. Phase 5 follows a reinforced strategic information system, including IT-enabled client-centric data platforms to reduce duplication and enable tailored services.
And the legal and social side? How do we write two crisp lines for stigma and rights?
Note that Phase 5 treats stigma reduction as a measurable goal. People living with HIV and key populations facing stigma or discrimination should be brought down to less than 10%. The HIV and AIDS Prevention and Control Act 2017 prohibits discrimination in employment, education, housing, healthcare, insurance, and public office, and it requires informed consent and confidentiality. This legal shield enables services uptake.
Final question, Dr. Joshi. Common pitfalls?
Students often A. List older targets from previous phases, B. Forget to mention stigma and rights, C. Skip the find link and retain emphasis, and D. Ignore differentiated prevention for injecting drug use. Anchor your answer to Phase 5 language, quote at least two numeric targets, the 80% reductions and the 95-95-95, and mention the legal framework.
That was crisp and high yield. If this helped, subscribe, like, and tell us which national program you want next. Thanks, Dr. Joshi.
Happy revising. Use those pauses to recall and you will write a confident, structured answer on Phase 5 of NACP.